Hi, welcome to my audience. This is Zoom MD Doctor's Corner podcast. We are having this session with Dr. Richard Daniel. He's a board certified radiologist and diplomat in venous and lymphatic medicine with decades of experience in minimally invasive vascular care. Welcome, doctor.
Hi, everybody. How are you?
I have a question for you for people or for patients who are meeting you for the first time. How would you describe who you are as a physician and what drew you to vascular medicine?
My background is interventional radiology, vascular medicine specialist. I treat dis arterial and venous disease in a minimally invasive fashion. So many things that I do used to be major surgeries with general anesthesia and significant downtime. And now through uh, either local anesthesia or light sedation, we're able to treat both arterial blockages as well as venous insufficiency with little or no incision and well tolerated and highly successful. Been doing it for about 25 years, and probably the best thing I can say about myself is I love my job. I love what I do.
Amazing, amazing. That's definitely rewarding. The next question I have for you is you bring a unique background in radiology and venous medicine. What makes your approach to vascular and vein care different from other clinics?
Well, venous disease has changed a lot over the years, and as I had said, it's used to be major surgery. Now everything is very minimally invasive. We treat the whole patient. When a patient has venous insufficiency, there's a multitude of symptoms. Probably the most common is like achiness, heaviness, ankle swelling, like cramps, restless legs. So we're able to diagnose the disease well. Our ultrasound techs are the best. We diagnose the disease well, educate the patient. There's always that opportunity for additional questions from the very first visit to the final follow-up. And so we are able to diagnose the disease, treat it well. Patients feel better. They come back very
Hmm.
happy.
The next question, I think that's, I think probably the most controversial treatment that I have came across is GAE. So, what would you like to share about the GAE procedure that would help potential patients feel comfortable and confident, especially those looking for alternative to knee surgery?
Right. Genicular artery embolization is an exciting new procedure. It's been around in this country maybe 2 to 3 years. I've done over
Mm.
2,000 of them. It
Wow.
was developed really in Japan, and
Mm.
over time we've perfected the techniques. What arteries,
Mm.
how many arteries to treat, how much solution to put in, what type of solution to put in.
Mm.
It is, as any new procedure, has gone through the steps to get approval. And I can say from experience, my 2,000 patients come back for their other, for when they come back for, when they do one knee, they come back for the other knee. They're very uh, satisfied with the results. Initially, the National Arthritis Foundation wasn't familiar with the procedure. So we presented it to them, discussed it, gave them the research, and through our efforts, the National Arthritis Society now recognizes it as a valid procedure. It reduces pain, likely reduces inflammation.
Mm.
There are multiple treatments. None of them are perfect. Even knee replacement has
Mm.
a certain percentage of patients with residual or recurrent discomfort. Knee injections, great, don't last as long. So genicular artery embolization is a proven procedure that really works and has good results for a good period of time. Our typical patient has success, significant success, more than just like
Mm.
10%, but
Mm.
significant success and improved mobility for a year or two. So the official
Oh.
stat is 70 to 80% of patients have significant success for 1 to 2 years, which really delays knee replacement. Uh, there's
Oh, okay.
patients who are going to end up needing knee replacement, but
Mm.
this will delay it. And
I
also
got it.
patients who
Okay.
aren't candidates for knee replacement, it's a great
Mm.
procedure as well.
Okay, so basically you're saying GAE is not really a replacement for knee replacement, it's basically to delay it.
Yeah, it's not a replacement. There are a fair number of patients with mild to moderate disease who
Mm.
have this procedure and eventually not need and not eventually need knee replacement. When we
Mm.
see somebody with severe knee arthritis, we
Mm.
treat them. and they do have results. But when you have pretty severe arthritis, they're eventually going to need knee replacement, likely. But if they're
Okay.
not a candidate, this is something that can be done an
Mm,
additional time. So if somebody has great results and then a year or two later they come back, we're happy to
okay.
do it again, and we see good results with them.
Well, that's great. So, but then that creates another question. So, do you think that somebody who needs knee replacement, this is really a band-aid then?
Technically, yes, but if you
Mm,
reduce the pain and the inflammation, and they postpone the knee replacement, that's
mm.
what many patients are looking for. So to
Oh,
either
okay.
postpone it or eliminate it, or in someone who say isn't a candidate. So
Okay. And is there any like age requirement for this for
no, we
GE?
have young patients
Mm-hmm.
with premature early arthritis, and
Mm-hmm.
we've had patients well into their 90s
Oh,
who
really?
the procedure had great results.
Oh, wow.
So
In
there's,
in, in the
like everything
90s?
in medicine, there's ideal ages,
Yeah,
but
yeah, yeah.
there's no cutoff.
There's no cutoff. And then is it so? Let's say for a patient, somebody who is in the 90s, are there any other diseases that could make it more riskier?
No, this is actually a pretty safe procedure. It's minimally invasive procedure, so
Mm,
we don't require cardiac clearance or an anesthesiologist. Well
mm,
tolerated with local, maybe a little bit of light sedation. So of
right.
course, if someone has medical comorbidities, we're a little extra gentle on that sedation,
Mm.
but everybody tolerates it pretty well.
Okay, awesome. Good to know. That's definitely new in US, and that's why I think many doctors don't know about GE, and obviously the patients are also not aware about it, and they don't know about it. So, thank you so much, Dr. Daniel, for being with us. And I think we will be talking more on this in the future sessions. We plan to do it every month, and so we'll be talking more about GE and other things that you have to offer to the patients at Optimal Ankle. Thank you for joining us.
Very
Take
good.
care.
Thank you, sir.